From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
Hello, and welcome to this JAMA Author Interview. I'm Dr. Linda Brubaker, Associate Editor for JAMA, and today we're talking with the authors of an original investigation, Effect of Fractional Carbon Dioxide Laser versus Sham Treatment on Symptom Severity in Women with Postmenopausal Vaginal Symptoms, a randomized clinical trial which appears in the October 22nd, 2021 issue of JAMA. Dr. Fiona Lee is the first author, and Dr. Jason Abbott is the senior author. They and their co-authors are at the School of Women and Children's Health within the University of New South Wales, a research-intensive university in Sydney, Australia. Welcome to both of you.
Thank you, Dr. Brubaker. It's a pleasure to be here.
Thank you, Dr. Brubaker. Pleasure to be here.
Dr. Lee, could you start us off by explaining why fractional carbon dioxide laser is being offered to women with bothersome postmenopausal vaginal symptoms?
Absolutely. As we know, menopause is an important topic in gynecology and warrants further research. And we know that vaginal symptoms affect up to 60% of women after menopause. At the moment, unfortunately, there are limited options in the way of treatment, with the mainstays being topical hormonal treatments as well as topical non-hormonal treatments, including lubricants and creams. And these have limited effects in women for the treatment of their symptoms. So fractional carbon dioxide laser has been investigated and offered as a treatment for vaginal symptoms. And it was important to us that we investigated this, given that it had initially demonstrated to be so effective in prospective trials earlier. However, there had been no high quality data to demonstrate the efficacy of this for vaginal symptoms.
So it sounds like the prior non-randomized studies that have included 16 prospective studies and 7 retrospective studies and 3 RCTs that included a total of 179 participants showed no superiority of the laser. None of these prior RCTs were double-blinded or placebo-controlled. And Dr. Abbott, I wonder if you would share some of the limitations of the prior studies in this area.
Thanks, Dr. Brubaker. And I think you've really hit the nail on the head with regards to one of the issues that we see in all kinds of medical devices, and that is comparing them against sham and doing that at an early stage. What we have in this particular technology is an initial group of studies that showed efficacy just in longitudinal programs. Then we have a small group of studies that compare it not in a sham setting, but comparing it against the treatments that would be routine, such as estrogen, and that didn't show any difference when you compare the two treatment types, but none of these are sham controlled. What our group did was to think that this was an important topic, that there may have been some biological plausibility in it, but thinking that we needed to go back to a placebo control, and in this case a sham control because it's a medical device. And what we did is we looked at some previous evidence, and there was some work out of the United States from Carolyn Mitchell's group that showed that estrogen, in fact, wasn't any better than placebo. And so that's where we got the impetus to look at this device versus a sham control, and again, came up with the fact that there was no difference between the sham group and the intervention group. And that's really important, I think, when we're considering that this is a device that, in this situation, doesn't look like it has too many issues in terms of risk. However, it is an intervention and it does have cost associated with it. And it's really important that we give factual information to women who are suffering from postmenopausal symptoms.
Thank you, Dr. Lee. The study had co-primary outcomes, symptom severity and the vulvovaginal symptom questionnaire. Could you talk with our listeners a little bit about why you selected these two for your co-primary outcomes?
Certainly can. The co-primary outcomes that we selected with a visual analog scale to assess for symptom severity was focusing on a number of different vaginal atrophy symptoms. In particular, we focused on dryness, burning, and itching of the vagina, as well as dyspareunia. And additional to this, we also incorporated the vulvovaginal symptom questionnaire, which is a validated questionnaire assessing for vulvovaginal symptoms. And the reason we've chosen these co-primary outcomes is because we felt that it was important that we focus on participant and patient-reported symptoms and severities as the outcome to assess the efficacy of this treatment. Many of the other studies that have been performed already, notably the prospective studies and the other non-placebo controlled trials, had also incorporated other outcomes such as physician-reported outcomes like the Vaginal Health Index, as well as laboratory outcomes like cytology and histology, and had demonstrated some difference in this. But I think what we were focusing on, and we had assessed these as well, but what we were focusing on is that if we weren't able to demonstrate improvement actually, then clinically this wouldn't be really an important difference at all.
I think it's also really important to remember, as Fiona says, that these are qualitative outcomes that we're trying to assess. And unlike, a specific issue such as death or time to recurrence for cancer or blood pressure, we don't have those same quantitative measures. So it's really important when we're thinking about the qualitative issues and quality of life that we try and get parameters that give us both a generic range, and that really comes in the visual analog scale, and then focusing in very much on that intensive vulvovaginal symptom questionnaire, where we ask women very much the issues that they want resolved with their presentation to their practitioner. And that's really the crux of this within this particular study.
Thank you both. Dr. Lee, could you describe how you designed the sham intervention for this study? What were the key features that you wanted to include for the sham?
As we wanted to design a strong double-blind sham-controlled study, a number of the features that we had to incorporate into the study was creating a treatment that, from a participant experience during their blinding, was identical. Essentially, we were able to use settings on the laser for the sham that was able to output a zero energy compared to the full laser treatment as recommended by the manufacturer. Additional to this had some benefits from a blinding perspective in that the tactile as well as the visual experience was the same for all patients in both groups. And all of the auditory sort of sounds and smells, the entire experience was identical in both groups as well.
Dr. Abbott, the study began with vaginal cytology and then changed to full thickness vaginal skin biopsies due to technical challenges. Why was it important to include these assessments?
It's a really good question, and it's certainly something that we looked at quite carefully and cautiously when we were trying to assess what we were going to do in this study. Vaginal cytology is relatively easy and very familiar to gynecologists because we do it all of the time with cervical cytology. Vaginal cytology is a little bit more challenging, and we certainly came across some of those issues within this study where we thought it's a much more gentle procedure for participants, and we took vaginal skin cells. But in the menopausal woman, sometimes the cytology is much more difficult to read and preserve from the vaginal skin. And therefore, we didn't have very good reliability when we studied those initial samples. And so we made a decision that we would then convert to collecting skin samples and using a skin biopsy. It's definitely much more invasive, and we are incredibly grateful to our participants, most of whom consented to give us some skin samples, which is amazing in and of itself. And this is one of the primary outcomes that was assessed in many of the previous studies that had been undertaken, where what they were saying is when we did laser, we could demonstrate a change in the vaginal skin. And they did that with cytology, but also with biopsy. I think it's important that we step back from that and say, well, that's actually just a pathological outcome. It's a histological outcome, and it doesn't necessarily relate to the symptoms. In fact, what we demonstrated was that when you take what would be considered a fairly objective measurement, that is a skin biopsy, we still didn't see any difference in the outcomes between the two groups, whether they had had laser or whether they had had the sham treatment, even when we took those much more invasive skin biopsies that the patients allowed us to do. So it gave us a real insight into the fact that this was a treatment that had some biological plausibility, but we weren't seeing that conversion even in those much more objective scales that had been previously reported.
I see. Dr. Lee, so given that there was no clinically or statistically significant difference detected in the outcome for the 85 participants who completed the 12-month follow-up, how should clinicians now incorporate the findings you report into their recommendations for women with bothersome postmenopausal vaginal symptoms?
From the findings of our trial, given that we were unable to find any statistical or clinical significance, our recommendation moving forward would be further research into this, but currently wouldn't be able to clinically recommend the fractional carbon dioxide laser treatment for vaginal atrophy symptoms, and therefore falling back onto the previous mainstays of treatment that we've mentioned before, including topical hormone treatments where appropriate, as well as non-hormonal treatments, and continuing to use those for the management.
Thank you. Dr. Abbott, I'd like to talk a little bit now about the secondary outcomes. The study had 5 secondary outcomes, some of which are included in this first manuscript. There were no significant differences detected between groups in quality of life or the vaginal health index score or the histologic findings as you've just described. Was this at all surprising?
Surprising is always an interesting word to use, I think, when you're coming to sham-controlled studies and placebo-controlled trials, and I try never to be too surprised. We want it to be comprehensive. I think that was the key here, because we had gone to such a lot of effort and we were asking so much of our participants. We wanted to make sure that we were covering a complete range of different ways of trying to demonstrate efficacy of the treatment or lack thereof, if we're looking at it from a sham controlled perspective. And when we took things like quality of life's a complicated issue. And we know that women who have substantial vulvovaginal postmenopausal symptoms can really have a big impact on their quality of life. And so previous work, again, had demonstrated that there was an improvement in quality of life. So we included that. We wanted to try and determine what clinicians thought was important. And that's classically what we've seen change over many, many years, where we've moved from what doctors think is important to what the patient thinks is important, because that's what it's all about. And that's where the VHI came in, the Vaginal Health Index score. And that had been used in more than 20 previous studies. And we definitely wanted to include that because we could then have a comparison between using this particular index in our study versus all of the other studies that had previously incorporated it as well. And when we'd had some discussions and set up some steering meetings early in the piece, many people said, you must get histology, you must get cytology to get a very objective and demonstrable outcome of how this is affecting the tissues. And as I mentioned previously, it's not necessarily important how it affects the tissues. It's how it affects the symptoms. And asking the patient is the most important parameter here. And I think that that's what we came down to. So overall, when we looked at both in our primary and our secondary outcomes, where we didn't see any change in any of those outcomes, then I think that really tells us a big story. And it's one of the reasons that we just cannot recommend this as a treatment outside of any research protocol. And I think people need to be really cautious and careful about how they are representing this to their patients if they're using it in a commercial setting.
Yes, I think every clinician listener can agree with the fact that symptoms don't come in the way of, gee, I'm bothered that my histologic findings are not normal.
So true.
So, yeah, obviously setting aside oncology patients and abnormal pap smears. But moving on, Dr. Lee, let's talk a little bit about some of the limitations of the study. You and your co-authors commented that there was potential that trauma from the sham intervention could have contributed to symptomatic improvement. Could you discuss this potential mechanism and whether there's actually a need to study the sham intervention alone?
Certainly, one of the limitations we considered arose from the fact that both groups did demonstrate an improvement and change over time after treatment. However, we were unable to demonstrate a difference between the laser and sham groups after treatment. Therefore, we had to sort of go back and think sort of what effect it was having in the sham group, apart from acknowledging the placebo effect itself. And one of the things we thought of was, given that it was an identical treatment and replicated in both groups, the way that the laser treatment is performed has a certain number of motions moving the probe through the vagina. And the stretch and the movements alone may have been able to sort of effect a little bit of trauma in that epithelium and stimulate some sort of repair process, which is what was theorized to be the effect of the laser itself anyway. I think the important thing to consider is that the laser itself was not demonstrated to be any more effective than the sham procedure. So whilst there may be some sort of room for future research regarding the impact of some sort of trauma effect and a sham procedure itself, an investigation further into that would be a low priority.
I think it's also really important to remember that not only would it be a low priority, and we spoke a little bit before about whether we were surprised by any of the outcomes. One thing that we definitely weren't surprised by was that there was a placebo effect at all. And it's really important in everything that we do in medicine to recognize that there is a definite power just in talking to patients and interacting with them. And that placebo effect has been demonstrated over and over and over again in medical interventions, in medical devices like this one that we've assessed, and in surgery as well. So the fact that we did demonstrate that, I don't think is a surprise at all.
Very, very interesting. Dr. Abbott, let's talk a little bit more about one other limitation that you and your co-authors talked about, and that was the inability to detect a difference in women after breast cancer versus those women with natural menopause. So given the overall findings of this study, what are the implications of conducting further randomized trials in the subgroup of women with vaginal symptoms who are essentially precluded from vaginal estrogen use because of their breast cancer?
This is such an important topic, and we know that women who have breast cancer, particularly estrogen sensitive breast cancers, where they don't use vaginal estrogens, won't use vaginal estrogen, it's not recommended to them to do that, really can suffer quite markedly from iatrogenic menopause if they are a young woman. And we certainly had young women with breast cancer, and we wanted to include them so that we were getting, again, that breadth of different types of menopause, both natural and iatrogenic. Here, and I will have to say that we were underpowered really to detect a difference. But those women, when we compared breast cancer with women who didn't have breast cancer and had a natural menopause, they were exactly the same in their patterns and outcome measures, whether they had laser or whether they had the sham protocol. Whilst we could hypothesize that, well, there might still be a change, or there might still be an improvement, and whilst there might still be a benefit in doing this, that marginal improvement seems like it's going to be very, very small. When we entered into this study, what we had was a range of prospective evidence that really showed very high rates of efficacy. What we've demonstrated is that those rates are not nearly as high as they were first suspected. That, as I've just mentioned, there is definitely a placebo effect when we do this intervention. And importantly, if we do want to show that there's a difference, you're going to need a huge number of participants. And that means that there's going to be a large number of people treated to have any effect. And, we talk about a minimally clinically important difference. And it's really hard to define what that means. Is it 10%? Is it 20%? Is it 50%? And it's different things to different people. And I think that that's what we're going to potentially see in the future with this device in women with breast cancer, where they may say, I am happy with a very small change. But if we want them to have what most people would consider a substantive change in what is not a cancer, what is not going to be a life-threatening condition, then we're going to have to accept that that difference in their outcome is going to be quite small. And that's going to be important for us to assess and to put into any future recommendations for research.
Thank you very much. Well, our time is running short today, and I'd like to thank Drs. Lee and Abbott for joining us today to discuss the study, which appears in the October 12th, 2021 issue of JAMA. This episode was produced by Daniel Morrow at the JAMA Network. The audio team here also includes Jesse McQuarters, Shelley Steffens, Lisa Harden, Audrey Foreman, and Mary Lynn Furkalup. Mike Berkowitz is the Deputy Editor for Digital Media. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening. I'm Dr. Linda Brubaker, Associate Editor for JAMA, and this is the JAMA Network.